Hello, my name is Joost Drenth. I'm a gastroenterologist from the Radboud University Medical Centre in Nijmegen, the Netherlands. And I would like to share my experience with respect to the diagnosis and management of polycystic liver disease. I've structured my talk as follows. I would like to talk about polycystic liver disease and explain to you that there are two phenotypes, as well as tell you a little bit about the management of polycystic liver disease, whether surgically or medically. There are two major phenotypes that can give rise to polycystic liver disease. First of all, you have autosomal dominant polycystic liver disease, where you have cyst in the liver, but not in the kidney. This contrasts with the situation in ADPKD, where you have cyst in the kidney, hence the name polycystic kidney disease, and you may or may not have a polycystic liver disease. Polycystic liver disease extends a wide range. Patients have multiple liver cysts, arbitrarily defined as more than 10 liver cysts, which leads to hepatomegaly. And you can see that a large liver volume can displace other abdominal organs. At the left side, panel A, you can see a mild phenotype, and on the right side, panel C, you can see indeed a patient with a very severe phenotype, where you can see that the other organs are compressed and being displaced to the lower abdomen. And it is no wonder that these patients have a severely impacted quality of life. Not so much on the social functioning and the psychological functioning, as well as the physiological functioning. And you can see that those patients have more bodily pain, experience a worse general health, and have a lower role with respect to the physical efforts that they can deliver. Here is a spider graph of the typical symptoms you can see in polycystic liver disease that are related to the large liver volume. And we have distinguished three phenotypes: patient with mild, moderate, and severe polycystic liver disease. You can see that mild patients do not often have severe symptoms, while patients with moderate and severe polycystic liver disease may experience problems with early satiety, pain or pressure in the rib cage, abdominal pain, limited mobility, and problems with intercourse. If you assess these patients, you will do laboratory tests in these patients. Normally, you will not see any abnormalities in the liver synthesis. However, if you measure the liver enzymes, you can find elevated gamma-GT or alkaline phosphatase. Also, in the majority of these patients, you will find elevated carbohydrate antigen 90.9, which is a biomarker for cancer. We've seen that it can be raised in patients with cyst infection, and that brings up the question whether it's a follow-up as a biomarker for cyst infection. cINate 90.9 is in particularly elevated in cyst fluid compared to serum levels. We also noticed that there's a gender disbalance in patients with polycystic liver disease who present with their disorder at the outpatient clinic. If you see a large slate of patients with ADPKD and you select them on the basis of their renal function, in this case at the left panel between 30 and 60, almost 50% of males and 50% of females will have polycystic liver disease. On the other hand, if you focus on the patients who come into your clinic with severe symptoms of polycystic liver disease, the majority of these patients will be female. And that makes us wonder, what are the risk factors for severity? Indeed, liver volumes are larger in ADPKD compared to ADPLD. Also, younger age, that is less than 51 years, is associated with larger liver volumes. And that brings into the question whether estrogen exposure is related to larger liver volumes. So we polled approximately 300 patients with severe polycystic liver disease. We distinguished 3 groups: mild, moderate, and severe. And we asked them how long and whether they have used estrogens. And indeed, the use of estrogen was associated with a liver volume in these patients. And per 10 years, they added on average 15.5% in liver volume. So the advice that we give our patient at this point of time is to stop with the use of exogenous pill. I will highlight 2 complications of polycystic liver disease. First of all, vascular obstruction, and then cyst infection. This 67-year-old female with ADPKD came to us because she was left dyspneic after a nephrectomy which was done in this patient. She had pleural effusion, and also upon scanning, we discovered that she had a polycystic liver and that the cyst actually obstructed the hepatic veins. So this patient had a hepatic vein outflow obstruction. And this can be the cause of portal hypertension. In this lady, she developed ascites and pleural effusion. And you can see that that can be a problem in these patients. Also, a portal vein obstruction by a strategically located cyst can be a cause of portal hypertension. And the third problem that these patients can have is that the inferior caval vein gets obstructed by a large cyst, and that these patients will develop an inferior caval vein syndrome. Let's move on now to cyst infection. Most patients with cyst infection will have abdominal pain and fever and an elevated acute phase response, such as CRP. We found that within our research that cultures are of moderate diagnostic values. Not all the patients with cyst infections have positive blood cultures. And indeed, most cultures remain negative, and there is no support, no evidence to support the use of routine microbiological cultures. We do it all, but the results are quite disappointing. So that's why we rely on cyst aspiration as the gold standard, or FDG PET scanning to confirm probable cases. For management, we give ciprofloxacin because that's the only drug until now where we know that they will penetrate into the cyst. And the scan at the right side is an example of ciprofloxacin concentration into cystic lesions in the liver. Cyst infection can be particularly a pesky feature because the recurrence rate of hepatic cyst infection is high, approximately 20% after, let's say, 1 year. The mortality in these patients can be present and is approximately 10%. One risk factor is renal disease, in particular if the patients have hemodialysis or have had a renal transplantation. And one of the problems with cyst infections is that there is poor penetrance of the antibiotics in liver cysts. Here is a graph of cefazolin penetration into liver cysts, which is virtually absent. And these patients will have subtherapeutic intercystic levels of antibiotics. So that's why we give our patients with recurrent cyst infections, which can be a problem, selective digestive tract decontamination. And here you can see the start of the SDD in these patients, which greatly reduced the incidence of hepatic cyst infections after start. So this is actually a strategy that we follow at this current point of time. And now let's move to management of polycystic liver disease. And I will highlight 5 different options. Well, first of all, a patient with a large dominant cyst in a normal liver or in a liver with polycystic liver disease. So, a large dominant cyst is defined as a cyst larger than 8 centimeters, which can be managed conservatively or with aspiration sclerotherapy or with laparoscopic fenestration. So let's move on to aspiration sclerotherapy. This is a procedure where we aspirate the cyst fluid contents out of the liver. We inject the cyst remnant with sclerosant, mostly ethanol, and then we remove the sclerosant and leave the cyst alone. And this is in particular a quite effective procedure. We see that in the patients, there's a reduction of cyst volume as well as cyst diameter, and that the recurrence rate, 21%, is relatively low. It's limited in invasiveness, and the disadvantage is that it takes time to have its full effect. Patients will gradually find an improvement in symptoms. And here you can see a disease-specific score, the PLDQ, which is lowering step by step after weeks after aspiration sclerotherapy. So in the end, aspiration sclerotherapy is a good therapy for large symptomatic dominant cysts, where you have a limited number of large cysts. Laparoscopic fenestration is an alternative for aspiration sclerotherapy. Here, you remove the dome of the cyst, where you expose the remnant of the cyst to the abdomen. It's an effective procedure. Symptomatic relief is seen in more than 90% of the patients, and it has a low recurrence. It's invasive and comes with certain costs, such as the surgical procedure. And the complication rate, with approximately 10 to 12%, is relatively low. So, laparoscopic fenestration is well suited for laparoscopically reachable, larger cysts with a favorable hepatic anatomy, and in particular for cysts that obstruct the hepatic vein or the caval vein. Then we have the problem of massive hepatomegaly, as in this patient. The aims with surgical therapy in this case is actually to reduce the PLD size without affecting the liver function in order to provide long-term relief of symptoms. We do this with surgery, but unfortunately, there is no consensus on the optimal timing of intervention. There are 3 opportunities or modalities that we use in these patients: partial hepatectomy, cyst fenestration, or orthotopic liver transplantation. Resection. As you can see in panel A, where you have a normal left lobe of the liver with a polycystic changed right lobe of the liver, and those type of patients are ideal candidates suited for resection, in contrast to the patients whose CT is displayed in panel B, the lower panel. And here you can see the effects of surgical segment resection prior and after surgery. It is indeed a definitive treatment option for selected patients, but only suited for patients with localized disease, and requires an experienced surgeon and a team who can stomach the high rate of complications, which is at least 12% in the Gravien-Dindot grading system. The liver volume in these patients will drop by almost 2/3, and the survival of these patients is relatively good. And note that here on the horizontal axis, on the right graph, the years post-surgery are more than 25. So these surgeons coming from the Mayo Clinic have extensive experience with this type of surgery. Resection of such a polycystic liver in these patients results to a large improvement of symptoms. And this is the fruit of results of a prospective analysis. Let's move on to liver transplantation. For the few and happy, I would say. The British Association for the Study of Liver Disease find that patients with polycystic liver disease who have massive hepatomegaly and a poor quality of life should be referred for consideration of liver transplantation. And indeed, intractable symptoms due to mass of liver or pain unresponsive to cystectomy or severe complications secondary to portal hypertension may be candidates for polycystic liver disease. Well, if you select these patients, you will find that they will fare very well. It's a definitive treatment for patients and gives excellent results in terms of patient and graft survival. There are some disadvantages. First of all, there can be difficulties in explanting the liver. You find that these patients are in competition with patients who accrue MELD points and they fall out the MELD methodology. And of course, there can be transplant issues, in particular explanting the polycystic liver. So liver transplantation is a definitive treatment, particularly suited for patients with recurrent hepatic cyst infection and untreatable hepatic cyst complication, and also in the few cases where patients with polycystic liver disease may develop end-stage liver disease and have MELD points. So last but not least, somatostatin analogs in polycystic liver disease. And this is a medical option because cysts are lined with the cholangiocytes and cyst growth is due to fluid secretion and proliferation. And cyclic AMP drives chloride and bicarbonate secretion. And somatostatin analogs such as lanreotide or octreotide inhibit CAMP. And the net effect is that you find a decrease of fluid secretion and proliferation, resulting in a lower polycystic liver volume. Well, this is a graph, a water flow graph, coming from 3 clinical trials where physicians treated these patients with somatostatin analogs, lanreotide and octreotide, for 6 to 12 months. And you can actually see that patients who were on somatostatin analogs had a larger drop in liver volume than patients on placebo. And on average, you can expect between 3 to 6% of a decrease in liver volume after treatment of 6 to 12 months. Clinical trials indeed found that polycystic liver disease is more severe in young females, and that is what I have explained to you, and that's somatostatin analogs in polycystic liver disease will reduce the liver volume in the large majority of patients, independent of genetic disorder, ADPLD or ADPKD, independent of gender, but research actually found that the effect size is the largest in young females. In the next step of our research, we were interested whether ADPKD would be susceptible for somatostatin analog treatment. So that's why we developed the hypothesis that lanreotide protects kidney and liver in ADPKD, because we knew that in some patients, if you administer somatostatin analog, the result will be a smaller liver as well as a smaller kidney. So the nephrologist actually reasoned that perhaps if you give patients with ADPKD lanreotide, then they will have a better renal function at the end of the clinical trial, and the change of liver volume in these patients will be indeed a decrease. So we ran a clinical trial in the Netherlands, which was a multi-center randomized clinical trial, open label, that ran for 120 weeks. We selected patients with ADPKD with a clearance of 30 to 60 milliliters per minute. And we assigned them to either standard of care or lanreotide in a 1-to-1 ratio. We scanned patients on baseline as well as after 120 weeks. We selected in total approximately 300 patients for the renal protection part of our study, and approximately 170 patients for the liver protection part of our study. First, I will tell you about renal protection data. Unfortunately, lanreotide did not affect the decline in renal function in these patients. This is a graph which you can show that, as well as in controls, there's a decrease in renal function in patients on lanreotide, and there is no difference between both arms. Despite the fact that renal function did not improve in these patients, we found that lanreotide decreases the growth rate of the polycystic kidneys, but did not, as I've shown you, preserve kidney function. The right bar shows you the patients on lanreotide, the left bar on controls, and you can see that in both arms, the polycystic kidneys grew larger, but less so in the lanreotide arm. Now let's move on to the liver part of the story. We selected, like I told you, 170 patients on lanreotide and control. We saw that the average age was 48 in these patients, and patients were distinguished in groups with mild, moderate, or severe hepatomegaly. We saw that lanreotide in these patients decreased the height-adjusted total liver volume on lanreotide with approximately 60% of the patients. By contrast, patients with standard of care had only a drop in the total liver volume in 31% of the patients. If you calculate the differences, you can see there is a decrease in total liver volume after 120 weeks of approximately -2% in the patients on lanreotide compared to plus 3.92% in standard of care, which is a difference of almost 6% in these patients. So to wrap this up, somatostatin analogs are effective in patients with multiple hepatic cysts, in particular with diffuse cystic disease, with insufficient long-term relief by aspiration sclerotony or fenestration, and it is effective for a short period of time, while a longer period of time, over 120 weeks, is unclear at this point of time. So, at the end of my presentation, I think that polycystic liver disease can be seen in patients with ADPKD and ADPLD. Patients can have symptoms and a lower quality of life. They can develop complications, such as the hepatic cyst infections. The goal for our management is to reduce the symptoms and to improve quality of life. We do so by reduction of liver volume, and we do so that with surgical or radiological procedures, liver transplantation as a last resort, and patients can receive somatostatin analogs, which will not improve the renal phenotype in patients with ADPKD, but it will reduce liver volume with an associated improvement of quality of life and a lower symptoms. So in the end, I think you should offer these patients a tailored approach. With that, I would like to end my presentation and thank you for your attention.
Thank you, Dr. Drenth. Is there any question in the audience?
Fantastic presentation, Dr. Drenth. Congratulations. My question is regarding the type of gene mutated in polycystic liver disease. What is the role of the gene mutation, the mutated gene, in the progression and in the response to therapies? Is there any data according to this?
Thank you, Dr. Banales, for this fine question. We have done some analysis where we actually grouped patients according to genotype in relation to response, for example, with somatostatin analogs, and we did not find a very good correlation. That is to say that we think at this point of time that some 30 to 40% of the patients have a PRK-CHH mutation, which is the first recognized genetic abnormality in polycystic liver disease. And these patients tend to have, as a group, a more severe phenotype. But the data is not mature enough to really distinguish effects among genotypes.
Is there any other question?
Congratulations for your talk, Dr. Drenth. This is Agustin Albillos. Nice to see you on the air. My question is there any cutoff value in liver volume that defines patients who become more symptomatic? My question regards when you evaluate those patients for liver transplantation, and the assessment of quality of life is quite difficult. So there should be or there are some data suggesting that you need a minimum liver volume to associate patient symptoms with that value. Yeah, and that's important just to have objective scores and numbers to indicate or not certain interventions. Could you make a comment on that, please?
Sure. Thanks so much. This is an excellent point, I would say, and this is always a point of discussion or debate between liver transplant hepatologists and us as a referring center, because well, at this point of time, you mostly have qualitative tools in order to assess the severity of the disease rather than quantitative tools. So we frame patients with respect to polycystic liver disease in certain age brackets. For example, if we have a young patient with a large liver volume, and a female patient, we know that this patient is going to progress rapidly. That is based on the data that we actually have. So a young patient, let's say 35 years of age, with a liver volume of already 4 to 4.5 liters, that is a patient we focus on, and we tend to refer for assessment of liver transplantation. Also, we are doing now some investigation in order to see whether extrahepatic manifestations of polycystic liver disease, such as, for example, hernias, umbilical hernias or inguinal hernias, are more severe in patients with severe hepatomegaly, and that is indeed the case. We just did some research where we found that approximately 30 to 40% of our population with polycystic liver disease have hernias, and that is related to the liver volume. So I think a sort of cross between age, gender, and liver volume indeed will tell us whether the patients will progress. And that is indeed a very good research question. At this point of time, we are collecting data in order to address that question.
Can I make another question?
A last question, short question, please. We're running late.
Thank you. For patients with symptomatic hepatorenal cystogenesis and renal dysfunction, would you recommend the use of tolvaptan plus somatostatin analogs or other kind of treatment? Because I mean, the effect in the kidney of somatostatin is quite modest.
Well, if you have if you follow the indication of tolvaptan, you have rapid progressive disease with respect to ADPKD. You could do it at this point of time. I did not advise that for any of our patients, actually. But it's a good question.
Okay, thank you very much, Dr. Drenth.
Yes.